Hello and welcome to the Home Therapies Treatment Options presentation. My name is Lindsay Frazier. I'm the renal nurse educator here in the Eastern Zone. Today we're going to talk about the home first philosophy, informed decision-making process, some decisional aid tools, answering questions regarding home dialysis or identifying an ideal candidate for home dialysis, some home therapies including PD, home hemo, transplant, and conservative kidney management, home therapy training, and some adult education strategies. The home first philosophy is to encourage transplantation and home dialysis as the preferred treatment over facility-based hemodialysis for all medically, psychologically, and socially eligible individuals. For those whose preference does not include dialysis, conservative care will be supported. The mission is to promote, grow, and support home therapies in Nova Scotia. And the vision is that all eligible individuals are receiving a home therapy. Some principles and values of home therapies include partnership, empowerment, autonomy, patient-focused, self-management, values-based decisions, informed decision-making, respect for patient decisions, maximizing quality of life, building confidence and reducing fears, and overcoming barriers whenever possible. In the renal clinic, some education classes are offered pre-dialysis, including orientation and modalities class. Orientation is a review of the kidney function, diet, medications, and social aspects of kidney disease. This class is offered to all patients of the renal clinic in group sessions. The other class is modalities. It's a review of the renal replacement therapies. It's usually offered to patients with an eGFR less than 15, although sometimes higher depending on their disease process. This class is offered in group or individual one-on-one sessions. Generally, patients in the Eastern Zone are seen in the nephrologist's office when their eGFRs are greater than 30, and then referred to the renal clinic once they drop below this level. The goal of the orientation class is to slow the decline of kidney failure by following these recommendations: diet changes, medications, most often for blood sugar, blood pressure, and advice regarding nephrotoxic drugs, smoking cessation, lifestyle changes, and exercise. And as we know, knowledge is power. Making an informed renal replacement therapy choice consists of having the patient at the center of their care and supported by the renal clinic team, including the nephrologist, nurse practitioner, renal clinic nurses, social worker, dietitians, pharmacist, and their support person, just to name a few. Some factors to consider when making a renal replacement therapy decision include the patient's values, their age, their demographics. For example, how far do they have to travel to get to an in-center hemodialysis clinic? And also consideration of their comorbidities. In this slide, you'll see renal replacement therapy assessment tools that we use in the renal clinic when assessing to see if a patient is a good candidate for home therapy. The first two tools are electronic tools: My Kidneys, My Choice, and Kidney Campus. Kidney Campus, I believe, is well known. And the last tool, Sherpa Decision Aid, is a paper tool. This tool we were trialing in the renal clinic in replacement of the MATCH-D assessment tool. The Sherpa tool is more detailed. I'll attach the links to these tools in the email. Again, other resources for home therapy assessment tools are some really great videos. Again, I'll put the links to these videos in an attachment to the email. I recommend reading the kidney dialysis website from Baxter. They have some really great information in there as well regarding home therapies and decision making. All patients do not attend education classes for a variety of reasons. Denial, for example, when it comes time to make a decision choice, sometimes they put it off because they do not want to make the decision because they're in denial. Others don't want to attend a group session for privacy, but we know that patients are more prepared to make decisions if they have the knowledge. Who and what we tell patients influences their perceptions, decisions, and even their prejudices about each modality. Patients surveyed revealed that much of their anxiety stemmed from uncertainty. Some of the anxiety stemming from fear of self-cannulation, the training program, and the shift of medical responsibility from nursing to themselves. Initially, when patients were surveyed, they expressed anxiety when they were expected to perform tasks they felt were reserved for medical professionals. Another thing to consider is when we expect patients to make a decision about a modality, oftentimes they're feeling unwell and can't process the information that we're giving them. Patients are informed, though, that they can revisit home therapy education at a later date if they wish. This is a great question to consider. Does in-center hemodialysis pose the least burden on patients and their families? In fact, it has the highest burden of any modality in terms of life disruption, including travel, access issues, hospitalizations, and dialysis hangover. When I'm talking about dialysis hangover, I'm referring to the physical ups and downs of hemodialysis. For example, cramping and fatigue and hypotensive episodes. Emotional upset comes from patients who make friendships in the dialysis unit and the emotional upset that happens when they die. Also, we have to consider it's the most challenging treatment plan with the greatest diet and fluid restrictions, the greatest number of medications, and low schedule flexibility. The reality is, in-center hemodialysis patients are taking on plenty of the responsibility of dialysis, but not giving themselves the credit. When a patient asks about home therapies, it's an opportunity to revisit what barriers to home therapies they perceived when making their initial renal replacement therapy decision, and what has changed since then. Offer information about home therapies. Patients who were educated in the clinic at times don't remember what they were told because they were feeling unwell at the time. Even if a patient doesn't ask themselves and you feel they would be an ideal home therapy candidate, ask them if they ever considered home therapy, and if they did, what prevented them from doing it. It could spark conversation and interest. We know that modality education increases home therapy choice 2 to 3 times. We know that teachable moments arise, and we have to take these opportunities. How do you think you can incorporate teachable moments or these conversations into your practice? Teachable moments could be when patients have to change their access, or if you find that they're not happy in center, if they ask questions, or if you just identify them as a good candidate. In other centers, they have modality meetings, interdisciplinary modality meetings routinely to review all new in-center hemodialysis starts. Even with our efforts to educate everyone, sometimes people are missed. For example, acute starts who may have not gone through the renal clinic. The goal is to assess 100% of patients for home therapies, ideally prior to starting in-center hemodialysis. Some benefits to home therapies include increased dialysis with better clearance, schedule flexibility, self-identified improved quality of life, no need to travel to a dialysis center, control over care and self-management, and cost savings. We're going to talk about 4 home therapy treatment options, including peritoneal dialysis, home hemodialysis, transplant, and conservative kidney management. This presentation isn't geared towards teaching everything there is to know about these modalities, but just basic information in order for you to feel comfortable answering questions patients ask. The first modality, peritoneal dialysis, we'll talk about first. This picture shows a PD catheter as well as an extension set that's attached to the end. PD catheter insertion is done either surgically or through interventional radiology. It's inserted into the abdominal cavity. Then PD solution or dialysate flows into the peritoneal cavity through the catheter in an extension set, as we've seen in the previous picture. The peritoneal membrane acts as a filter. There are 2 types of peritoneal dialysis, manual and automated. We'll talk about them in more detail. There's no needles or blood exchanged. It can be done by yourself or with the help of a support person. There's 24-hour support from the clinic as well as through Baxter, the company that deals with our PD supplies and equipment. And home care is available in most areas. This slide just shows the cycles of a PD exchange. So first you drain the old dialysate from the peritoneal cavity. You fill with clean new dialysate. Then you disconnect from your catheter and let that solution dwell. Generally it's morning, so there would go breakfast, lunch, supper, and bedtime. Each exchange takes roughly 30 to 40 minutes. Peritoneal dialysis is a process of cleaning the blood using a specialized solution and a semi-permeable membrane, which is your peritoneal membrane. The peritoneal membrane is a thin, porous layer of tissue with numerous blood vessels, and it's semi-permeable. The membrane is composed of 2 layers. The parietal layer lines the abdominal wall, and the visceral layer covers the abdominal organs. The space between these 2 layers is called the peritoneal cavity. Normally, this cavity contains 10 to 50 mils of solution, but can hold several liters without patient discomfort. 2 types of peritoneal dialysis include automatic and manual. The first is the manual, also called twin bag or CAPD. Again, there's 4 exchanges normally, but there could be a 5th if more clearance is needed or more fluid removal. It's done during the day with a nighttime dwell or a last exchange before bedtime. There's a picture of a twin bag with your full dialysate and your empty drain bag, which connects to your PD catheter for your exchange. On the library services site, you can access the directions to do a twin bag. I can attach this link to the document as well. There's a 12-step sheet, 1-pager for doing the exchange. There's also automated PD, also called cycler or CCPD. This is dialysis that occurs overnight while you sleep by a machine called the cycler. So the cycler will do those exchanges while you sleep. You hook up once, and then you can disconnect in the morning when you wake. You could have a daytime fill. Generally, your prescription's for 8 to 10 hours with 3 to 4 exchanges. There's a picture of a cycler, and attached are larger solution bags which contain all the solution you need to do your exchanges overnight while you sleep. Considerations for peritoneal dialysis. You have control over your own health care, self-manage, and independence, more flexibility in schedule, can travel with PD supplies, home support, VON is available in most areas, 24-hour support from a registered nurse from the renal clinic or through Baxter. Most can have a more liberal diet with less restrictions, better fluid balance and blood pressure control. The cost of PD is approximately 25% lower than hemo. And it also noted that patients who are on PD maintain some residual renal function longer than they do if they, in comparison to hemodialysis, and there's no needles. Some more considerations. It's daily dialysis rather than hemodialysis where you could have 3 treatments per week. There is considerable amount of supplies, so you need storage for these supplies. There is a PD catheter inserted into your abdomen, limitations to swimming and bathing, ability to connect and disconnect from the cycler or twin bag. There are risks involved, for example, peritonitis, exit site, or tunnel infections, risk for hernia or leak. There's some physical restrictions, including no lifting over 20 pounds, body image, and some people are not a candidate due to multiple reasons. One is, for example, multiple abdominal surgeries. In this presentation, I'm not going to expand on barriers. If you feel there is someone who you think is an ideal candidate, bring them forward and they can be assessed for barriers, because a lot of barriers can be overcome. Training for PD. Generally, patients need to train for 5 days in their renal clinic for peritoneal dialysis. There's follow-up appointments every 3 months or as needed. Patients learn to do twin bag and cycler if they choose that option. A support person is recommended for home therapies. Again, VON is available to help set up cycler in most areas. And accommodations and meals are provided for patients who are traveling to train. This slide I included just to let you know that there are 13 PD policies on OP3 and an excellent learning module if anybody's interested in learning more detailed information on peritoneal dialysis. you can certainly go ahead and do the learning module. Moving on to home hemodialysis. This picture is of one of our patients here in Eastern Zone. He kindly allowed us to use his picture. He's been on hemodialysis, home hemodialysis since 2013, doing very well. Home hemodialysis is a little bit more involved in terms of training and commitment to, I suppose there's more to learn and more work to do at home. It requires a home assessment, 6 to 8 weeks training period with a registered nurse in the clinic. Again, there's 24-hour phone support. Recommended to have a support person. It does require some plumbing and electrical modifications to your home. Of course, that's covered through the renal program, but a quote is required. There's a water system, an RO, reverse osmosis, or DI system. Again, you need space for your supplies and care of your CVC or self-cannulation is required. In this picture, it shows a RO water system that was installed recently into a patient's home. As you can see, there are some home modifications, so you require a drain and some electrical outlets for your water system and machine. In saying that, the patients do have to learn how to maintain this water system. So heat disinfections and chemical disinfections with their water system. They also have to learn how to set up, connect and disconnect from their dialysis machine and troubleshoot, as well as care for their access, whether it's a fistula or a CVC. The prescription could look like short daily dialysis, regular conventional hemodialysis, or they can also choose to do nocturnal dialysis overnight while they sleep. Benefits include doing your dialysis in the comfort of your own home, better anemia management, flexibility in your schedule. They can have less medications, better fluid balance, blood pressure control, overall feeling of wellness. Some can have a more liberalized diet, increased independence, improvement of left ventricular hypertrophy, and it's more cost effective. Some disadvantages include home modifications, as you've seen. Some people feel that they are turning their home into a hospital environment. If patients do not own their own home, they have to have approval from the homeowner to do those modifications, which is not always granted. Caregiver burden, increased waste, and increased water and power bills. Moving on to the next therapy is kidney transplantation. Nephrologists generally transfer the patient to the transplant coordinator for a transplant workup. Initially, they are seen by their family doctor for a history and physical, including weight, height, BMI, some initial blood work, including tissue typing and group and screen. And some people are excluded at this point due to a BMI over 40, a history of cancer within the past 5 years, or heart disease, just to name a few. CORE, or the Canadian Organ Replacement Registry, is a national database that provides statistics to track long-term trends for dialysis activity, organ transplantation, organ donation, and wait list statistics. Canadians living with end-stage renal disease, 42.5% have a transplant, and 57.5% are on dialysis. And this comes from the Kidney Foundation Canada website. One question that patients often ask is, how long do I have to wait for a transplant? The average time in Canada for a deceased donor is approximately 4 years. And of course, this does vary depending on the match of the kidney to the recipient. 27% of kidney transplants are made possible by living donors, in which 45% are unrelated to each other. The survival rates for transplanted patients is excellent, 92% from living donors at 5 years, and 82% from deceased donors at 5 years. Some considerations for kidney transplantation: it is not a cure, it is a treatment. Not all kidney failure can be treated with a transplant. Transplants are performed in Halifax. Live kidney donation usually is done laparoscopically for shorter recovery time. Again, our kidney donors can be living donors or deceased donors, so a cadaver donor. Who can be a live kidney donor? You must be over the age of 19, have not been diagnosed with diabetes. If you're under the age of 40, cannot have a history of hypertension. If you are over 40, it may be okay if it's controlled with no more than 2 blood pressure medications. No active malignancy, have not been pregnant or given birth or had a miscarriage within the last year, not breastfeeding. If there is a history of kidney stones, there has to be further investigations ordered, and a BMI less than 40. Benefits of transplant: mimics your own kidney function, no dialysis, more liberal lifestyle, feeling of wellness, able to resume career activities or school, follow-up care in the renal clinic. Again, considerations: it is a surgical procedure. There is blood work on a regular basis along with clinic visits. Anti-rejection drugs are forever. And of course, these medications have side effects. Need to diligently follow a healthy lifestyle. And there is a possibility of a rejection, which can usually be treated. And finally, we'll talk about conservative kidney management. Conservative kidney management is a treatment option. Some patients decide not to have dialysis or transplant for personal or medical reasons. Medical treatment and support is continued by the renal clinic team, and medications are used to manage symptoms. We have to consider that dialysis may not help everybody live longer or improve their quality of life. For some, the side effects of dialysis may even lower their quality of life and make them feel worse. Dialysis won't treat other medical problems, for example, diabetes, heart conditions, arthritis, pain, and dementia, just to name a few. The burden of dialysis, for some, is not worth the benefits. The goal of conservative kidney treatment is to ensure your comfort and symptoms are management. Patients are informed they can change their mind at any time, and having a plan for this modality is key. Again, some patients will not live longer or feel better on dialysis. Again, on library services, there's a pamphlet that we can resource for advanced care planning. I'll attach the link to this pamphlet as well in the attachment. One resource I used a lot when I worked in the renal clinic was CKM Care. It's a website. It's excellent for anything conservative kidney management. Tons of resources. It is everything from decisional tools to symptom management guidelines, action plan tools. The goal is to support patients and family members by treating or preventing symptoms, maintaining kidney function, and supportive care, which includes medical and psychosocial. Having action plans to help avoid ER visits or hospital admissions, unless really necessary, is key. This pathway is busy. It's kind of difficult to see in this slide. It's from ckmcare.com, and it just is a review of the pathway for a patient choosing this modality. And it really emphasizes planning. In the next slide, you can see more clearly the second, step 3, where it really talks about planning. So the key is planning, advanced care planning, crisis management planning, end-of-life planning. We really would like to have plans in place to keep patients at home, comfortable, without having to go to ER. And of course, the renal clinic is always a resource. Another consideration for educating our patients regarding modalities or home therapies is using some adult education strategies. So using a combination of teaching strategies and teaching materials is the most beneficial for adult learners. Whether it's an one-on-one session or a group session, allowing time for questions is key, and also following up with them. Adult learners prefer printed materials, pictures, and graphic work, videos. All different multimedia increases patient satisfaction and increases understanding of information. Adult learners often have a problem-centered approach and are interested in content that has direct application to their lives. They want to learn what is meaningful to them. They also bring years of knowledge and experience to their learning and have an established system of values. Again, give patients time to respond, limit medical terminology or slang, provide short explanations or short discussions, and identify goals. Some take-home thoughts from this presentation. If you identify a patient that is interested in home therapies, talk to them about their options and notify the nephrologist or renal clinic. The patient can be booked for a clinic appointment to have a one-on-one session. This gives them the opportunity to ask questions, get more detailed information, and discuss treatment and training plans. Patients can and do change from one treatment option to another. Revisiting renal replacement therapies with patients on in-center hemodialysis once they have started to feel better and are more comfortable with their dialysis treatment is really beneficial. Listed are some references. And if anybody has any questions, please feel free to reach out to me through email or call. I'll be happy to answer your questions or give you some more information. I hope everybody enjoyed this presentation and took something away from it that you can incorporate into your practice. Thanks very much. I look forward to hearing from you.